Hello everyone. Let me welcome you to our World MS Day occasion conference today at Bombay Hospital. This conference is being done by Bombay Hospital in collaboration with MS Society of India, and our topic today is navigating life and the newer treatments in MS. And we are going to have a wonderful panel of doctors with the topmost neurologists of Mumbai and India, starting from Dr. Singhal and his team and the MSSI team that is going to talk in detail about the topic today. I'm sure all of you are going to have a very good informative session. So let's go inside so that we can start the session. Thank you.
My name is Kranti Munje. I am an MSP and I am an honorary secretary for MSSI Mumbai chapter. It's a pleasure for me to host this event today, and I would like to, of course, begin with thanking Bombay Hospital for having such a wonderful gathering of all specialists, and I'm sure all of us are going to learn a lot, and people have so many questions every day around, and I'm sure we will have a lot of answers for those also, and I'm sure questions will be asked and you all will have all your answers. So having said that, this is going to be a wonderful session As you see on the screen, the title is Navigating Life and Advancements in MS Treatment. So, of course, all the patients here know what we navigate every day. So, we are going to have really more insights on how we do this all day long. So, we are going to start. I'm going to welcome all the dignitaries today. Welcome, sir. Welcome, madam. It's only because of all of you that we are going to have such a wonderful session. So, welcome to this session. We will start with lighting the lamp. So may I request all the dignitaries to come ahead so that we could light the lamp and start the session. Thank you, everyone. The flow of the events is going to be, I'm going to introduce all our dignitaries today, followed by address by Dr. Patil, Dr. Singhal, and Dr. Khadelkar. That will be followed by national anthem. And then we have a talk by Dr. Singhal, Dr. Varsha Patil, followed by panel discussion. So I'm going to be introducing all the doctors here. So we have Dr. Rajkumar Patil, Medical Director. Welcome, sir. It's a pleasure to have you. Dr. B.S. Singhal, again, needs no introduction to the patients here. Here is MD Bombay, DSC Honors, FRC. Dr. Varsha Patil, is stay here? Sorry. Director of Neurology, Department of Neurology, Bombay Hospital, Mumbai. Founder of Parkinson's Disease and Movement Disorder Society, PDMDS, and Neurology Foundation. Areas of specialization are multiple sclerosis, myasthenia gravis, and has over 200 publications to his credit. Padma Shri Awardee winner. Dr. B.C. Roy National Award, the R.D. Birla National Award, the Priyadarshini Academy Award, the Wockhardt Award for Medical Excellence, and the Dhanvantari Award. So welcome, sir. Dr. Satish Khadelkar, MD, DM Neurology, DNBE, FIN, MNAMS, Dean and Head of Department of Neurology, Bombay Hospital, past President of Indian Academy of Neurology, ex-Secretary of Indian Oceania Myology Center, again, areas of specialization, neurology, neuromuscular diseases, and over 200 publications to his credit. Welcome, sir. Dr. Varsha Patil, MD, DNB, DM Neurology, Fellow Child Neurology, Consultant Neurologist, Department of Neurology, Bombay Hospital. Areas of specialization are autoimmune neurology, that is MS, neuromyelitis, sorry if I immune encephalitis, immune neuropathies, pediatric neurology, epilepsy. 22 research articles and 13 book chapters to her credit. Senior editor for neurology, 5-minute consultant, South Asian edition. Achievements and awards, first rank in DM neurology, prizes for best platform, ICTRIMS 2023, and poster presentation at national conferences, faculty at various national conferences, and joint organizations, organizing secretary for midterm conference NAMS. Welcome, madam. Dr. Rajiv Nerurkar. I don't, are you there, sir? Okay. So please come ahead and sit. Sure, sir. MS ENT DORL, Senior ENT Surgeon and DNB Teacher, Bombay Hospital, former Chief ENT Surgeon, Municipal ENT Hospital, Honorary ENT Surgeon to Mumbai Police and the Governor of Maharashtra, affiliated to Bombay Hospital, Mumbai Police Hospital. Past affiliations are to AGVM Municipal ENT Hospital, on Advisory Committee of Association of Otolaryngologists of India, Mumbai. Specialization is otology, neuro-otology, and auditory revoked responses. Achievements, organizing secretary for phonosurgery workshops, faculty at skull base and otology workshops. Welcome, sir. We have Dr. Mrinal Pandit, BPT, MPT Neurology, PhD Neurology from National University of Medical Sciences, Florida, USA. Fellow in NDT Mumbai, affiliated to working with Bombay Hospital for 27 years, affiliated to Indian Association of Physiotherapy, member of American Association of Physiotherapy, founder of Physiotherapy Department in TIFR, and on the medical advisory panel of TIFR. Areas of specialization are designing various rehab programs for various neurological cases with graded protocol. Myopathies, brachial plexus injuries with special interest in rehabilitation of OBPP, and has publications in IAP journals, IFSHD and WIROC. Welcome, ma'am. Dr. Dhaval Gusalia, MSCH Urology, affiliated to Bombay Hospital as consultant urologist. Area of specialization is endourology, genitourinary malignancies, female urology, has 3 publications to his credit. Welcome, sir. We have Dr. Jharna Mahajan, DM Neurology, gold medal, MD Science, MBBS, Associate Consultant Neurologist at Bombay Hospital. Special interests are general neurology, neuromuscular diseases, has 6 publications to her credit. First rank in DM Neurology, prizes for best platform presentations like IANCON 2024 BNA, prizes in various quiz competitions. Welcome, madam. I'm going, next is Mr. Sandeep Chitnis. He is National Secretary for MSSI. Sandeep Chitnis is Fellow of the Indian Institute of Chartered Accountants. He is also a certificate holder in business valuation from the Institute of Chartered Accountants of India. He has been a senior partner in a couple of chartered accountant firms. He is also director, including as an independent director for 5 companies on company boards. In social sector, he was in Rotary for many years, served in all leadership positions, including as president at the club level, and also served on Rotary district. Currently, he is also a director on the board of Sushrusha Hospital. Currently, he has been National Secretary at MSSI India since 2021. Earlier, he was National Vice President from 2015 to 2021, at MSSI. He's also on CEO advisory group of MSIF since 2021. So welcome, Sandeep. Yeah, we also have Dr. Rekha Bhatkande with us. She also needs no introduction, a known face in Mumbai and also across India. She is an MD General Medicine, 1976 from Grant Medical College. She's a gastroenterologist from JJ Group of Hospitals, and she has also done her hospital management from Symbiosis. Her interest and specialty is gastroenterologist, and also she is committed to social health, and she has done immense amount of work in the social health sector. Until as of yesterday, I may say, she was Dean with Sushrusha Citizens Hospital, Dadar, Mumbai. She has lot of present publications, etc. to her credit. Currently, she is the vice chairman for MSSI India. She is president Family Welfare Agency Mumbai, president Dilasa Group of Senior Citizens Mumbai. She is also former president for Gastroenterology Research Society of Mumbai. She is member of multiple organizations that work in the social sector. She is editor with Swasthya, a biannual health magazine, patron with annual Marathi River, JB Vacha School, Mumbai. And yeah, there's her biodata just goes on. She's recipient of YB Chavan President Award in 2013. Jitesh Jiset Seva Bhushan, NISD, MOSJE 2023. Welcome, madam. With this, I would request Dr. Patil, Dr. Singhal, and Dr. Khadilkar to address the group here.
Thank you for this, elaborate introduction of all the faculty members and all the invitees. On behalf of Bombay Hospital, I stand before you to, with proud and privileged, because it's my privilege to welcome you all on behalf of Bombay Hospital Trust to this evening's program on this multiple sclerosis. Of course, we have stalwart speakers, none other than, of course, Padma Shri Dr. B.S. Singhal, whom we always love to hear. So please give a huge round of applause to Dr. B.S. Singhal. And of course, the other faculty are, they are all upcoming faculty. Of course, Dr. Satish Khadilkar is there, Dr. Varsha Patil, Dr. Jharna, and of course, Dr. Rajiv, Dr. Dhaval, Dr. Mrunal Pandit, all the, Dr. Mr. Chitnis, and of course, so all, you will love hearing their talk, and you will feel that this fellow will waste your time. So I don't want to waste your time. Only thing is that on behalf of Bombay Hospital Trust, it's my privilege to welcome you once again to this August gathering, and I hope you have a fruitful evening. With these few words, I will like to stop here and give the chance to Dr. B.S. Singhal. I invite him for the brief introductory talk. Thank you.
Very good afternoon. Can you hear me? Dr. Patil, Dr. Khadilkar, my colleagues on the staff at Bombay Hospital, MS Society Executive Committee, MS warriors and caregivers, very warm welcome to this meeting of the MS Society. We are really missing Sheila Chitnis, and I hear that she's unwell. I pray and wish her speedy recovery. I think many of the things about the multiple sclerosis that you will hear has been listed over here. So I don't need to read out. It's not a contagious disease. And you can really, with your willpower, do quite a lot. So I think later on in the talk, I'll mention to you how you can live well with multiple sclerosis. And as you know, many of them have been, despite the handicap, been a warrior, struggling with the disease and overcoming the difficulties that they have. And I think I see Anita Vesuvalla and the new secretary here, and Sandeep Chitnis, who has taken over the mental now. So wish you all the very best, and thank you very much for inviting me here. Thank you very much.
Good afternoon, everyone. Let me welcome you to this afternoon's function. I welcome you in two capacities. One is the Dean of this institute at the moment, and we're very happy that you're all here in Bombay Hospital. And the second is a long-standing member of the MSSI. For some reason, I'd taken out some old photographs the other day, and there was a lovely photograph of 1993 of probably the first panel that MS Society conducted. Professor Singhal is there, Professor Wadia is there in the photo. And that was my first interaction with the MSSI in 1993. And this is a fantastic society. I work with many patient organizations. I mainly work with muscular dystrophy organizations, a little bit with some others. But this organization I find one of the best in terms of the office bearers, in terms of the patients. I don't know where they get so much enthusiasm from, how much knowledge they have. When an MS patient who has been with MSSI comes to the clinic, you know how much he knows. So I've been tremendously impressed by the MSSI and its work, and all of you, all these years. MS is changing, new things are coming. So it's only appropriate that on the MS Day, we have a program like this where we exchange our ideas, see what new is happening. And I'm looking forward to the interaction that will follow in the next 2 hours. Most of the times I meet patients in the consulting room, which is slightly different. But in this forum, we can interact more freely. And please do ask all your questions to all the faculty members who are here. So let me welcome you again for this program. Thank you very much.
Yeah, all those who can stand up, I would request to stand up so that, we can have our national anthem. Very good afternoon once again. I think it is important to understand what multiple sclerosis is, to live well with multiple sclerosis. This is the forward. I'll do that. Maybe this is up. Well, this is a disease of the central nervous system. As you know, the central nervous system and peripheral nervous system.
In central nervous system, we include the brain, the spinal cord, and the optic nerve. And this is some sort of immune disorder. That means, our immunity gets affected, and this is an autoimmune process, and we can get more relapses. Oh. I think in the nervous system, we have the neurons, they are the cells, and we have the tracts. And the tracts, the main tract is called the axon, this is the wire, and surrounding that is the insulating material, that is called the myelin. And what happens in multiple sclerosis, as you can see, that around the vein there's an inflammation. And the myelin is lost. And at the same time, I think unlike what we used to believe earlier, there's also the fibers start getting damaged early on, and that's the axonal degeneration. Now, this disease has been known for over 200 years. The father who first described was a French neurologist, Professor Jean Charcot, who's called but even earlier, there are descriptions in the Western literature where you find that there are descriptions suggestive that the multiple has existed for a long time. But in India, we recognized multiple sclerosis only in the 70s. Before that, most of the physicians thought they didn't exist. And the reason basically was that the committee met called the Schumacher, and they decided to decide about the disease on clinical grounds. That means if there's an affection of the eye or brain or spinal cord symptoms, visual disturbances, double vision, imbalance, walking difficulty, bladder disturbance, and it has to happen at different times. That means, so there's a dissemination in time and space. So that is how we used to diagnose multiple sclerosis. Till, as you know, a big revolution came, and we have now what is called as MRI, magnetic resonance imaging of India. Magnetic imaging. And this MRI can depict the lesions in the brain and the spinal cord, and therefore it made the diagnosis easier. There was a New Zealander who settled down in England by the name of McDonald, and the committee met to decide as to how to diagnose multiple sclerosis. So they can demonstrate in the MRI various lesions which appear as white dots, and if they're active, when you give the contrast, they become very active. And of course, it's optional, but if you do the lumbar puncture as a diagnostic test, there are some, or what we call oleochral bands. They demonstrate that there's an inflammation occurring in the nervous system. So they have revised the criteria with a view to make the diagnosis earlier and earlier. Now these are some of the pointer is showing the lesion in the spinal cord. And you can see some of the spots which are juxtacortical. Some of them are around the ventricles and some in the posterior part of the brain. Now these are the typical sites where the multiple sclerosis occurs. Now, of course, the physician, Dr. Khadilkar, Varsha Patil, Jharna will exclude other diseases which might mimic multiple sclerosis. There are other demyelinating disorders which we have come to realize, but they are not multiple sclerosis. Say, for instance, Varsha mentioned about neuromyelitis optica. We've got the MOG-associated disease. We also have only optic neuritis and recurrent optic neuritis. And also sometimes, you see the lesions and the person is ill with many lesions all over, particularly the children. So now multiple sclerosis usually affects the young people. That is the tragedy of the disease, that the onset is between the age of, say, 25 to 35. It can happen even later. And of course, the females, for some reason or the other, are more affected than men. The unfortunate part of multiple sclerosis is that it's an unpredictable course. Person may remain well for 3 or 4 years and may have an episode, or may have a quick episode. And if there are repeated episodes, and of course, if there's axon degeneration right from the beginning, they can get disabled, so that, they may have to use some ways to walk. Now, multiple sclerosis, as you know, occurs all over the world, and there may be about 2.3 or 2.5 million worldwide. In India, we used to think it is probably, less, 1 per 100,000, but now we think it might be 515. But even that might be an underestimate. I think every neurologist happens to see the multiple sclerosis patients. Now, this is just a diagram. You see the blood vessel, and there are cells in the blood vessels. They get activated. They cross the blood-brain barrier. They get into the nervous system. They produce some, chemicals and cytokines and macrophages. They affect the myelin and produce the demyelination. So in fact, multiple sclerosis sometimes exists even before you diagnose it clinically. That's called a radiologically isolated syndrome. I mean, a person gets a headache, MRI is very easily available in India, and you find that there are multiple lesions. That is probably radiologically isolated syndrome. And then there may be a person presenting for the first time with tingling and numbness, or little weakness in the leg, or little imbalance. That's the first episode. And then they may have more relapses. And then, of course, over time, many years later, there might be a further progression and may get more and more handicapped. That's called a secondary progressive. Now, we do not want that stage. There are also some cases right from the beginning they are getting worsening. There's another group of diseases called the primary progressive MS. Now, what do we want to do? We want to control the inflammatory component. So in the acute phase, what we do is we give them steroids intravenously. If they're no better, we go on to plasma exchange. And there are therapies, so that we immediately control the inflammation. And then, of course, we try to give the treatment so that there are no more relapses and no more worsening. So there are several drugs available, which I'll mention to you. And of course, the therapy should be well tolerated. There should be no side effects. And of course, in India, it's very important, it should be cost effective. What we do not want is the person to become handicapped has to use a wheelchair or scale or anything. Now, there are many therapies. In fact, from the 2005 onwards, every 2 years or 3 years, you will find a new drug coming on. Now, there are now drugs which are very, very effective, so that the people get no evidence of disease, either clinically or in the brain or spinal cord. That's called as the no evidence of disease activity, called as NEDA. That's a term that they use. They start the treatment early. So I won't go into all the details now. You will hear about the ultimate choice is that of the person himself who is suffering from multiple sclerosis. So that the doctor will discuss all the drugs, and depending on the severity of the case, will decide which drug should be given. We'll give a suggestion. Now we have what are called as B-cell depleting therapies every 6 months. And we also have a new chip on the block, which is a BKT inhibitor, just approved. Now, depending on the severity of the case, if the person has got the weakness or imbalance or bladder dysfunction, we give a very effective therapy. That's called an induction therapy. If the person is case of mild, then we may begin with a more simpler drug, which has been used for a long time, can be given orally or injectable. So this is the escalating therapy which we have been using. The induction, that means you begin with a very severe, very effective drug first, and then after 3 or 4 years, when the person is more stable, come down to the less effective therapy. I won't go into this, because the mode of action of the drugs at different places. Now, there are certain issues which are very, very important. As you know, many of the people who get multiple sclerosis are young persons, young females. They're about to get married, or if they're married, they want to have children. So one of the very important issues is to discuss, because some drugs are harmful and some drugs are useful. So I think they have got to take the drug before becoming pregnant and discuss with the doctor when they want to have the children. so that they can use the drug which can be continued during pregnancy if required. Drugs like interferon injections can be continued. We also have, in the more severe cases, drugs like natalizumab, which can be continued intravenously. So I think this aspect has to be discussed very, very carefully because majority of these are, and you'll be surprised, many of them are already IT people, who got the disease. They've read all about it on the internet. So I think we have to, there's another thing which is very important. When you give this treatment, the immunity goes down further. As the immunity goes down further, you got to reduce the risk of getting infection. So that before we give the treatment, which is highly effective, we got to make sure that they don't have a TB which might get activated, or they've got any other illness. So we do certain tests, like the Australia antigen for hepatitis B, hepatitis C, TB, and the others. And of course, we have to vaccinate them. There's certain vaccination which should be given. One of them is the quadriflu vaccine, which is given every year. Pneumococcal vaccine, even other people which are healthy should take it. Pneumococcal vaccine, there are 2 doses, 2 months apart. And people certainly over the age of 50 and those people who have multiple sclerosis should take to prevent herpes zoster. So I think Varsha is quite an expert on that. If he has included that, she might tell you more about it. There's another thing which people have realized, that we have a gut. I think what you eat and what sort of flora you have is extremely important. So there's a lot of discussion on what is called a microbiota. You'll be surprised in many of the immune diseases, the gut acts like a second brain. Illness can begin over there. So there are certain flora, now you may even find that these are available as capsules and all. They are given to the patients to use, useful. For us, of course, drugs like anything that enhances the immunity will be useful, like turmeric. You can use in milk or food. Turmeric improves the immunity. So I think in multiple sclerosis, the scientists are really working hard. And that's the holy grail, to find the cause. The current hypothesis is some EBV virus, Epstein virus in the childhood predisposes some genetic factors, some environmental factors which result in causation of the first episode of multiple sclerosis. We want to prevent multiple sclerosis, that means NIDA. And of course, if there is we want the thing which is not available today is how to remyelinate, They were working in the mice, and in the mice they found that there was some lingo antibody. They gave the anti-lingo antibody and the mouse did very well. But unfortunately, this drug, which was tried in human beings, failed. So they're also trying how. So one important thing about the multiple sclerosis is that do not worry about what you've lost. Try to overcome that by rehabilitation and supportive treatment. But I think what also realize is that what you have, and that is why I call them the warrior. I had a patient who was very disabled. She was from Calcutta, but she was really a warrior. She used to come despite the fact that she had a catheter or using diapers. She could hardly walk, but still had the grit to try and attend our meetings over here. So someday I am sure this will happen. And in the meantime, of course, as you know, MS Society, as Dr. Khadilkar said, it is one of the best run societies. And this was actually started even before we knew much about the MRI and the treatment. That was 1985. And this is affiliated to the International Federation of Multiple Sclerosis Societies. In fact, I think, as Anita will say, I took quite a good part in it till I moved away to Parkinson's Disease Society and Neurology Foundation. They reach out to the patients. I think Geeta is here. She takes them also on picnics and all that, I think. Rehabilitation is free aids and appliances, workshops and camps. And Sheila has been a great person. I really miss her today. But I'm quite sure the son is carrying on. And I hope she recovers fully well soon to take over. And Anita Vesubala has also been a very active person in the society. I remember in one of the meetings, the 2 cyclists did a great performance despite their handicap of multiple sclerosis. And I think this society was started, as you know, by Toby Tobaccowala, who was then the chairman of the Voltas, and also Fazal Boy. And I think now they have chapters all over. So I think, as Dr. Khalilkar said, and I'm very pleased that today I could be a part of the Bombay chapter to share my views on multiple sclerosis. Thank you very much. This is the slide which I wanted you to see. Put the lights off. I wanted you to see. You'll see Sheila there. Can you put that bright light you put on? So you can see Sheila Chitnis over there. This is one of the patients, whom she is pushing in the wheelchair. And this was at the race course event, So I think it was quite they used to have a lot of activities every year. Thank you. I might myself that I won't be staying on because I have some other commitment. But I'm quite sure that Dr. Khadilkar, Varsha, Jharna, Dr. Nerulkar, and the others who are here will be able to answer all the questions. Thank you very much.
Thank you, Dr. Singhal. I'm Deepa, having MS and your patient. You talked of gut. So given the latest research going on gut, any guidance that you can give us in terms of the role of diet and certain foods to be avoided if they are inflammatory?
Actually, there's no practically, any proven thing, but they say that gluten-free diet is preferable. So as you know, wheat also has a gluten by switching on to jowar, bajra, etc. I think taking your fruits and nuts will be desirable. So I think that actually is the recommendation. As you know, there are isolated cases where one patient, took and found that she improved considerably. So you'll find isolated instances, on the internet and on the web. But there's no definite, from the scientific point of view, any research done on a special diet. But I think turmeric is good. Pardon?
It was dairy and dairy products.
Dairy products, I think, my feeling is, I think, very rich food should be avoided in general. I think some of the dairy products, like curd and all should be okay, where a probiotic should be helping the guts.
Thank you.
But you have any, because I think since sometimes, we learn from the patients. If you've done some research on that and you have something more to say, please tell us. Yeah, I think that's another thing, we learn a lot from the patients. Thank you.
Doctor, I have one question over here.
Please.
This way. So, doctor, we met one neurologist in Delhi and he talked about some black spots.
Pardon?
Black spots in MRI scanning.
Yeah.
So, is there something like that?
Then I'll tell you. See, what happens is black holes, they call it black holes. They only mean there's axon degeneration and you do not see any white spot. So this only is indicative, the black hole is indicative of axon degeneration. And the number of black holes, if there are more, that would indicate that the disease is more progressive.
Okay. Thank you very much, doctor.
No problem. Thank you. Have a great meeting ahead. Thank you.
Yeah, may I request Dr. Varsha? Dr. Varsha will be talking on the newer therapies and drugs that are there today.
A very good evening, everyone. It's a little hard to talk after Dr. Singhal has finished his talk, but I'll have to continue the show. So I'll be talking on newer therapies in MS. So basically, we are looking at the treatment of MS, and we're looking at 4 prongs. We're looking at the disease-modifying therapies, we're looking at symptom management, healthy lifestyle choices which Dr. Singhal just talked about, and managing the comorbidities. So what are the goals of treating MS? We want to minimize the relapses, we want to minimize the new lesions that come in the MRI, delay or prevent the progression of the disease, promote a better aging, and improve the quality of life. So when we talk about treatment goals, we're talking about acute therapies. That means the person has an attack, an acute attack. And then we need to treat that acute attack, which Dr. Singhal mentioned. I'm just repeating it again. The choices could be corticosteroids, which is the standard of care. And if it's a little severe disease or a severe attack, we're looking at higher immunotherapies, like your intravenous immunoglobulins or your plasma exchange. And obviously physiotherapy to improve the residual disability or weakness. But what about prevention of the further attacks? This is where is the role of the disease-modifying therapies, or what we call as the DMTs. Of course, there's been a huge change in the treatments of MS. When they started off just with the interferons for the initial 1990s, now we are into 2025, and I must say that there are lot more effective, lot more safer drugs, and lot more drugs which will still come in the future, because there's a lot of research going on how do we prevent the progression of the disease, how do we prevent the progressive disease, and can there be a possibility of a remyelination. So when should a DMT be started? The first question that comes is, Doctor, I'm okay with my attack. Should I not be not taking any medications? The answer is no. The answer to when to the DMT be started, start quickly at a young age, because when you're looking at the lifespan of this person who is only 20 now and going to the 50s, we looked at how the disability curve can get worse. So DMTs do help for a better clinical outcome and prevention of disabilities. So where are the different DMTs that are available? You have injectables, you have orals, and you have also what are called as monoclonals. I'll go over all of them as I talk in the further slides. So what are the injectable DMTs available? We have the interferons and the glatiramer acetate. These were the first ones that came in. So these are immunomodulatory, they are not immunosuppressive. So there's no risk of a PML here. There's a long-term experience because these are the first ones that started. There's a minimal safety and a modest tolerability issues, because anyone who takes interferons knows how the weekend is going to be after he's taken a shot on Friday. And not to forget that these are the safest of the DMTs for pregnancy. Vis-a-vis, we have the oral DMTs, which came much after the interferons, your fumarates, your dimethyl fumarate, the SYP modulators, your fingolimod or siponimod, teriflunomide, cladribine. These are very convenient because there are no needles. And efficacy is as good, or I would say rather a little better than your injectables. So now we're looking at the whole range of drugs. So you have what is called as the first-line therapies, then your highly active therapies, and what we listened to in the previous talk, the induction therapies. So again, there are different examples of each type that I've noted here. The earliest ones were your Copaxone, your interferon beta. Then the first-line orals, where we are talking about the oral DMTs, could be a teriflunomide or a dimethyl fumarate, and then a highly active drugs. What I mean by highly active, I'll talk a little later. So natalizumab, fingolimod, ocrelizumab, rituximab, ofatumumab, a little complicated names, but they are better in a selected group of patients. I would mention in a selected group of patients. Not everyone becomes a candidate for a highly effective therapy. Okay? And then you have the induction therapies like your alemtuzumab or cladribine. So this is just a pictographal representation, and we are looking at the newer therapies for MS. So as you can see in the circle, you have the anti-CD20 molecules, that's your rituximab, your ocrelizumab or your ofatumumab. Then we have your S1P modulators, and the newest ones, that is the BTKI inhibitors, the Bruton tyrosine kinase inhibitors. So what are these monoclonal antibodies that everybody is talking about in different groups, I am on this mAb, I am on that mAb, and this is help, this is not help. So these are high efficacy drugs, but they are immunosuppressive and they have some high risks. For example, a propensity for you to have infections. Amongst these mAbs, we have the natalizumab, the alemtuzumab. These were the earlier ones which were very highly effective, but this particular set, the anti-CD20, seems to be taking a lot of upper hand in most MS therapy centers where they're looking at trying to reduce the relapses, reduce the disability, and look at a little better clinical outcome for the patients. So we have the rituximab, the ocrelizumab, and the ofatumumab. So these are injectables. They can be either given as IV shots or as subcutaneous injections. When we look at these anti-CD20 therapies, rituximab seems to have been used for a very long time, and there was originally a very large study, about 882 patients from the Swedish group, which talks about how safe it is, how effective it is. And then later we had the Danish and the Indian studies where they also proved that rituximab was quite useful. But we have the finer versions, that is the ocrelizumab and the ofatumumab. These were actually approved by your Federal Drug Association. We can see that all of them are effective in different types of MS. So in your relapsing remitting MS, in your secondary progressive, and also your primary progressive MS. So going on a little more into the self-injectable drugs that's coming about, the ofatumumab, where it is just either a self-administered pen or a prefilled syringe which the patient can use. And of course, the first study which came for the rituximab was to show how effective it is. So when they said that they compared it with the placebo, I mean patients never received any MS-related DMT and the other group received rituximab. In them, they definitely found that there was a little reduction in the new lesions by about 3 months after starting the therapy. And of course, because the other group didn't receive a therapy, there was a little higher infusion-related adverse events in the rituximab arm. So in the Indian context, so this is the Salzar one is the study that I'm talking about, the Swedish, where they found that it was quite effective. Then of course we have Indian experience from our group with Dr. Singhal and also from the South with Dr. Thomas Matthew, where they talked about both the efficacy and the safety. And I can say now that we've been using it for quite some time with Dr. Singhal, that the drug is quite effective and quite safe. I'll not go into the nitty-gritties and details about it. Then of course the question came as, can we use a little lower dose of the drug and see whether it's effective? So there were a lot of studies which came again from the Swedish population where they said that the dose can be a little less than the usual 1 gram and it could be still effective in preventing your relapses. So at the bottom, these B-cell targeted therapies, how are they useful? They are highly effective. They are usually well tolerated, say, the incidence of infusion-related reactions, which means a rash or an itching or some sort of a reaction after giving the infusion in a proper slow rate infusion is usually about 7%, but very mild. And that's usually in the first or second infusion, because that's the time when the body is introduced to the drug. Further on, usually they do not seem to have a lot of side effects after the infusion. It's quite well tolerated, and the short-term safety is also quite good. When we're looking at long-term again, we're looking at the data from the US and the European populations, where they're using a little refined version of your rituximab, the ocrelizumab or ofatumumab. They have about 10-15 years of data. And they seem to be fairly good because the amount of severe infections that people have got while they are on ongoing therapy is quite less. The incidence of malignancies, I mean to say cancers, is also not more, significantly more than what it would be in the general population. Though when we're using these monoclonal antibodies, there has been now a lot of recommendations and there is a standard of care to ask whether the family has any history of breast cancers or ovarian cancers and be on the watch while you are on the therapy. So these are first or second line useful in moderate to severe MS. This is where I come again. These are not for all patients. These are not something which are going to start immediately. That means for a treatment naive patient. You have to select your patient properly when you're thinking about this highly effective and of course coming with their own side effect profile and coming with their own shortcomings. So again, the risk of long-term infection is what we need to discuss with the patient, but the safety data has to be still evaluated as we are going through years. In pregnancy, they found that these B-cell therapies are quite safe. There is very little fetal risk where they say there can be some transient neonatal thrombocytopenia or B-cell depletion, which is very transient and gets improved. There are not many reports saying there are malformations while the mother has received the B-cell therapy before getting pregnant. And during the breastfeeding also, it seems to be quite safe. These were the recommendations that came from the European guidelines, where they looked at the consensus recommendation while you're on anti-CD20 therapy during breastfeeding. So they say that can be used in women wishing to get pregnant. Women can safely start trying to conceive without delaying while they are on anti-CD20 therapy. And those who are with RRMS and have a recurrent relapse, the number of relapses being quite few before you start the therapy, there is a little caution that if you stop it during the pregnancy, there can be a little rebound and you may get relapses in your postpartum period. Breastfeeding is encouraged, so it doesn't seem to be crossing through the breast milk, and so there is relatively no risk to the infant. Rather, it would be very safe while you are breastfeeding, even while you're taking or you've stopped your anti-CD20 therapy. Dr. Singhal talked about immunization. Now that bit I didn't cover here because he had already mentioned it, but as we emphasize, whenever we start somebody on these highly effective therapies, we always consider having a review of their vaccination. Second point is that we need to vaccinate them for most infections which can be a high risk while they are on these immunosuppressant drugs. So we always ask for an annual influenza shot, the pneumococcal vaccine, your shingles, that's your herpes zoster vaccine, sometimes in young ladies even about the human papillomavirus vaccine and your hepatitis B vaccine. So once you're immunized, the risk of getting a very severe infection even while you are on these therapies is quite less. We also try to analyze whether, while you are on anti-CD20 therapy, the immunity seems to be going down. And then there was a time when COVID was a big scare, whether COVID really was too bad in patients who are on these highly effective therapies. And we found that it was still quite safe. Not many of our patients got a very severe infection. The only caution here remains is that while you are on immunosuppressant of any sort, so it's not just the anti-CD20. If you are on mitoxantrone or you are on other drugs like your natalizumab or your alemtuzumab or your fingolimod or your siponimod, you cannot take the live attenuated vaccine. What I mean to say is your varicella zoster vaccine or your MMR vaccine. These are a few more drugs which seems to be of a lot of promise, which is called as the Bruton tyrosine kinase inhibitor. So where we are looking at therapy for MS, we are looking at trying to bring down the inflammation which is caused by the antibodies, because the origin of your antibodies is from the B cells. So for a very long time we thought that the B cells need to be targeted. Hence we got those rituximab, anti-CD20 molecules. So your rituximab, your ocrelizumab or your ofatumumab, and there are a few more, the inebilizumab, which is going to come later. But after that, they started targeting also, looking at whether it can also reduce the immune complex mediated attack. So we have these Bruton tyrosine kinase inhibitors. Very complicated names, but they are saying that these could be quite promising even in reducing the inflammation further. The safety, however, remains a big question. The initial trials had failed because they were looking at liver damage because of these patients. They've now again refined the molecules, but it's still in your research phase. So when you're looking at giving newer drugs or your highly effective therapies for MS, you're looking at two things. Am I going to start this patient on treatment A, which is like the first line therapy, like your interferons or your dimethyl fumarate or teriflunomide, and then slowly try to increase as the patient has a disability or increase relapses? Or am I going to hit hard at the first time, induce, that means get the immunity, the haywire gone immunity to a stage where it is stable, and then come down or de-escalate? This decision basically is a joint decision. It is depending on what is your patient's profile. So when we look at roughly if a MS patient comes to the clinic, the first thing of course is diagnosing and giving the news to the patient and the family, then looking at the patient's overall profile. So is this a young patient or a little older patient? How is the first attack, or how many attacks has the patient had? How disabling was the attack? We look at the MRI picture. So how many white spots are there in the brain? Are there too many? There are more than 10. Are there more of those gadolinium enhancing or your contrast enhancing lesions? Because that is one pointer which say that the disease is quite active. And then, of course, we look at, are there any comorbidities? What I mean by comorbidities is, are there any other illnesses like your diabetes, hypertension, or other things, or other infections in the patient where you make a choice? Now, if it is, say, a young patient, a young girl, who has first attack of optic neuritis, and she has, say, 1 or 2 white spots in the brain and some few oligoclonal bands in the lumbar fluid, she's not the one whom I'm going to start her on your highly effective therapies. Versus, say, somebody in his 25s, a boy, okay, a male, having acute onset, double vision, walking difficulty, what we call as brainstem presentation, with multiple white spots in the brain. So he's got multiple periventricular, juxtacortical, spinal lesions with the optic nerve. 5 to 10 of them are enhancing. This is not the patient where I will discuss about interferons or dimethyl fumarate. I would be a little more confident in saying, look, it seems as if your disease is a little more highly active. It's a little aggressive, and I need to be giving you a little stronger drug to begin with. So here we will look at induction or your, what we call as induction strategy, or hitting hard. It is giving the high efficacy drugs at the first time. Okay, these are just 2 extreme examples that I am giving you. But obviously there is no black and white, there are grays. And then at the end of it, the choice of taking the drug is always a joint decision. So even within these molecules, so you have drugs which can be given IV every 6 monthly, and you have injections which the patient can himself take every monthly at home. It will all depend on the patient's choice. Some people don't want to take pills daily, and they probably want to take 1 shot and see, not take and not feel that they are sick for the next few. It is their choice. Or somebody who wants to take a drug but doesn't want to get hospitalized. It's definitely the patient's choice. As sir mentioned, we get so many of these people who are IT professionals. Forget IT professionals. Everybody Googles and comes these days. And so before, even if they walk in the clinic, they have their mental list of questions ready, at least 45 to 50, and then they have the doubts because Dr. Google told them that tomorrow, maybe say another 2-3 years, I'm going to probably go on a stick or a walker or a wheelchair. So it is a joint decision, and it is a longish conversation. It can't be just in a minute. Okay? Of course, going back again to these 2 strategies, in the real life setting, when they looked at a large population of patients, they definitely favored using an early intensive therapy to the beginning, so that there was a better clinical outcome and disability reduction. So when we're looking at high efficacy therapies, which are the patients of MS, where I will recommend them? Those who are having a moderate or a severe MS. When the second line orals, injectables, or other drugs fail, all right? And they can be used especially in this group of patients who are planning for the pregnancy. What are the other drugs that we're talking about in the pipeline? We have these sphingosine 1-phosphate receptor modulators. They are quite there in the European population, but still not available. And these are the oral drugs, which are there for your SPMS as well as RRMS. And there's another one which is quite a lot popular, and they are trying to see the efficacy-wise whether this cladribine may be helpful a little more for your active SPMS or your severe RRMSs. But again, it's not available in India. So the bottom line is, when you're looking at newer drugs in MS, you need to look at a favorable benefit to risk ratio and see whether they are generally well tolerated in the patients. They have a little reduced serious adverse events when you compare them with your interferon beta 1A or your teriflunomide. They're easy to manage during pregnancy, and as we said, you can have risk mitigating strategies, your vaccinations, looking at the history of exposure of infections, vaccinating patients beforehand, and early treatment if you find infections. So what is the take home? Therapies for MS are evolving with a better understanding of the pathophysiology. I mean to say, we are looking at B cells, we are looking at immune complexes, we are looking at natural killer cells. So there are molecules specifically trying to target each and every pathway of the inflammation. And so your window of treating the patients is enlarging more and more. Again, these novel therapies are available. They are soon going to also be the other drugs that I mentioned to you, the BTK inhibitors and cladribine will soon come even to India. But the most important is that you have to have a tailored therapy with an active involvement of the patient in the therapeutic decision making. This is the most important part of treating MS. I end with the World MS theme today, that is My MS Diagnosis, Navigating MS Together. Thank you very much. We have a panel discussion now, so I'll be happy to answer the queries in that. Thank you.
We can get into the panel discussion. So may I request Dr. Satish Khadilkar, Dr. Varsha, Dr. Jharna, Dr. Rajiv Nerurkar, Dr. Dhaval, Dr. Mrinal, Dr. Rekha, and Mr. Sandeep Chitnis to come on the dais, please.
Good afternoon, everybody. And I must thank Dr. Varsha Patil for asking me to conduct this very eminent panel, or rather panel of very eminent speakers, a discussion amongst them. The topic today for our World MS Day is navigating MS together. And we've got a brilliant panel here with us, so let's navigate the knowledge that we want to gain from them together. So, sir, Dr. Khadilkar, sir. You know, one of the questions that our MSPs always ask us in MSSI at our chapter is how often does the transition of MS from relapsing, remitting MS to progressive MS?
Right. I think that's quite an important question, and thanks for asking that. When somebody starts with MS, and there is the RRMS, something happens, it becomes better, the person goes back to life, forgets about it. Time goes by, again something else happens. Again they come to the doctor, steroids usually given, again they become better. So in the early part of MS, there is this relapsing remitting form, which is the commonest. And because it gets better, there is that little bit of false security that comes in. Okay, something is happening, doctor will give me 3 days of injection and I'll be okay. And so often we see people going away and not coming back till another attack comes, whatever you tell them. But if you look at the numbers of people in whom the disability starts accumulating, it's quite large. At the end of the first year or two, 10% people will start showing a little bit of continuous disability. And the number goes very quickly to 50% by the time it is 10 years, and goes to 93, 95% when it's 20 years. So almost all RRMS, unless somebody is very lucky, will move on to SPMS, secondarily progressive MS. So it's extremely important to understand this fact that RRMS is just the face of it, the tip of the iceberg. And therefore you got to take it seriously when it begins, because that's perhaps the best time when you can make changes. So the short answer is a lot of RRMS turns into SPMS, and therefore we've got to move quickly.
So here, are there any radiological signs, like maybe the brain volume or like the black holes that our MSP just mentioned?
It's a little bit unpredictable, but if there are these black spots which mean axonal degeneration, that usually means that more trouble is going to come. But these black spots may not come early. If they're there, they tell you that there could be a bit of problem. It is quite a bit unpredictable. I think the very fact that an attack has come means that you've got to be on your guard, even if it goes away in just 3-4 days.
So a lot has been said about patient care and the role of very early diagnosis. And
Yeah.
in, of course,
Yes.
multiple sclerosis.
Yes. I think we have moved in all immunological diseases to this thinking that the immune activity is maximally responsive to therapy when it begins. And therefore, treatment of MS has to be started at the earliest. Just like so many other immune diseases today of different parts of the body, we are starting treatments earlier and earlier. That's because when the immunological aberration has started, it's probably most responsive to something that you're going to give. So as we understand immunological diseases today, there is no question that you have to come in quickly with the best drug that you have, and you have to hit hard. You know, for a long time in MS, there was this paradigm that, okay, patient is having a mild problem, don't give a big drug, give something simple. Unless somebody has a big problem, big disability, big event that's not going away, don't start with the big drugs. But that's changed. Not changing, it has changed. You come in quickly, you come in with the most potent drug that you have, of course within the limits of its side effect profile and its negative damaging aspects. And you have your best chance of killing that immunological process early on and giving a good life to the patient where disability isn't that much. So current buzzword is come in quick, come in big.
Which means, sir, that you're actually saying that early intensive therapy is probably
Absolutely,
the best.
early treatment. Now, like Dr. Varsha showed in her presentation, there are parameters as to who is a highly active patient, who is not that highly active a patient. So it's a case-based decision. But the policy is to go big.
So maybe one day our escalation therapy won't be in existence anymore. Except
I
if
don't
your-
know.
if
I
your
don't know.
therapies don't
I mean,
work.
unless if our biomarkers to the disease behavior also improve, we may know that some patients may not require that big a therapy. But the biomarkers have to evolve like that. Till that time, it is much better to do more than to do less.
So what is your current recommendation? I mean, how would you start the treatment?
You know,
And what about DMT?
Yeah. I think one thing is certain, that a disease-modifying therapy should be started early. Now, how early? There are patients who have not an MS symptom, maybe a migraine or maybe something different, and you do an MRI, and you get MS type of MRI. Now, as you know, MRI has really got so accurate now that you can make a diagnosis reasonably confidently with an MRI itself. Like at the Grant Medical College some time ago, a new MRI machine was being fitted. So a radiology resident went into the MRI machine as when they were setting it up and came out with an MRI that fulfilled McDonald's criteria for MS. Now he had nothing. He was a normal boy. So the question then came, what are we going to do? And this was almost 15, 20 years ago. So we said, okay, we'll watch. Everyone who has a radiological problem doesn't become a clinical problem. So we actually waited on him till something came. If I saw a similar situation today, the advice will be to start a disease-modifying therapy. So radiologically isolated syndrome, clinically isolated syndrome, they're all being treated. For a time, the Americans were treating the first clinical event, the Europeans were not treating the first clinical event. But that's all merging into treating quickly. So disease-modifying therapies come on at the earliest. Now, which one to choose depends on the profile of that patient, where you see which structures are affected, what is the MRI showing, what's the frequency of events, and then you decide which is a good treatment. So still we have first-line therapies, we have second-line therapies, we have advanced therapies. And a lot of us will still go in an escalating paradigm. Use some which is a first line. Then move from first line to another first line. Then go to second line. But it's completely case-based. If you see someone who is not getting control with the first line, you probably will now jump to second line rather than shifting to another second first line drug. So it's all going towards early and fast moving.
And maybe personalized.
Completely personalized. Completely personalized.
Dr. Varsha, you've been talking about immunotherapy and high efficacy therapy. Could you just tell us a little bit more about that?
Yeah. So, as I mentioned in my slides and the talk, we're looking at highly effective therapies, which is probably a group of drugs where we are trying to target at the molecular level, looking at what is the pathogenesis. Do we think that the disease is antibody mediated, or do we think the disease is a little more complement or other mediated? Now, for your question, madam, see, highly effective therapies, we are looking at ultimately achieving a NEDA, which means no evidence of disease activity. That means no relapses, no new gadolinium enhancing lesions, or no increase in the T2 lesions which are existing, and no new disability. So this is where they seem to be having a lot of promise, because worldwide they are trying to use it. Now, there are again two schools of thought, as sir said, whether you hit hard. So there are centers where I know where the first drug that is given is a highly effective therapy. But I would differ, because ultimately it is a choice that you need to give, and it has to be a case-based, a personalized decision. You can't just give blankly these highly effective therapies. Again, there is a catch here. We're looking at India. We're not looking at Europe, or we are not looking at the US or the other Canadian or Danish population, where everything is covered by the government. We're looking at cost. We're looking at money which is going into the therapy. And so even if we talk about your interferons, or we talk about your dimethyl fumaric, even if they are generic ones, there will still be a patient who will think about the cost. For example, just last week, I had a young girl, 2 episodes of optic neuritis. I decided, she didn't have many lesions, so I decided to start her on dimethyl fumarate. She did quite well for a year with that. The father came back. It is not a very affluent family. His question was, do I keep pressing her to go for higher studies? Will that stress her more? And what about this? You know, when I took the injection, it was X amount. Now in this year, the company person told me that it's increased by another 1,000, 2,000, 3,000. How long do I give? So unfortunately, I don't have the answer of how long, but I can tell them that I need to have you on a clinical follow-up and then take the decision whether I want to escalate, de-escalate. Stop is really not there in my cards just now. I'll be very frank.
Ma'am, but where your B cell therapies are concerned, I think your appropriate, how long are you going to give it? That becomes a very big
This
question.
question is still not answered even by the best of the experts in the world. In the Indian scenario, it's sometimes very funny, because so many things are guided by a socio-economic status. To be frank, somebody can't afford, maybe they may push in and afford for a year, 2, 3. The question comes, what after the 4th year? Though, of course, now we have lot of reduction in the prices, and I wish the pharma companies also come ahead and try to look at a cost-effective therapy for everyone.
Is there anything as a support group? Is there anything we can do? You know,
Madam, they talk about rituximab being in the essential drug list by the WHO.
It is
So,
on the.
yeah.
It is.
So we need to push in a little more and try to get in the pharmas to cut down on the cost of these therapies. They are effective. So why not somebody who's not so economically well off be deprived only because they don't have the money to use it?
Sure.
Again, madam, this is a personalized decision. I am not going to start a highly efficacious therapy for everyone at the first instance. It will be depending on the patient's profile, the family's profile, the profile of the disease overall, including the biomarkers. Your biomarkers are very simple. You're looking at the clinical attacks, you're looking at the radiology, and you're looking at the disability rating. But there are in future a lot of more biomarkers which will come.
Sure.
That can help us typify whether the patient is a mild, moderate disease, and can I predict whether this patient is going to be a little more highly relapsing person.
Okay.
But ultimately, it's a joint decision and it's one-to-one decision.
Absolutely.
There can be no general yes or no to anything.
And as a support group, we're always going to try and help our patients make that joint decision with their treating neurologist. Thank you, ma'am. What about MS plan in pregnancy? You know, in the last 5 years, from our patient group, we've had almost, I think, 5 pregnancies which have, very successful deliveries, and babies were really very healthy. And so obviously something has been done right. But how would you, describe a
Pregnancy
plan?
in MS is itself a topic. It's again interesting. So the well-educated ones sometimes take the decision, I don't want to take the pregnancy, I don't want my child to suffer. So the first question really comes is MS hereditary? And is MS going to affect your pregnancy? The answer to this is clearly no. When we're looking at the percentage of children, of mothers or fathers having MS, the proportion is quite less. It's so minuscule that I would say it's near to no. So why shouldn't a person with MS plan to have a family? That's one. So second is, of course, MS does not affect your fertility. It does not affect the way you go through a pregnancy. It is quite safe. The risk for pregnancy is the relative risk that any girl of that age would have, including her other non-MS factors. And third, of course, now, even if she is on highly efficacious therapies, we've seen that they seem to be quite safe, except for a few. If I had to mention somebody who was on teriflunomide and gets pregnant, I would say please go and abort. We cannot take the risk of having a pregnancy here because the baby in the womb may be affected. Other than that, interferons, they are saying that you can actually safely continue them through the pregnancy.
Ma'am, one of the fears that young pregnant MSPs have is that if they're on safe DMTs or, treatment for MS and you've asked them to continue, what happens to the child? What happens to the baby? So what happens to vaccination in that baby? At birth?
That's a very good question, madam, because these are really generally the ones that come up to us. One thing is, of course, as I said, other than teriflunomide, the other ones are not that teratogenic. Though there is a safe period where you have to stop before you plan a pregnancy for most of the drugs, which you can always discuss with your doctor. If you are going to have a planned pregnancy, the idealist would be to plan a pregnancy. Of course, if you get accidentally pregnant, then we have to go through the routine and the standard care, go through a proper malformation scans, go through basic markers and see if the pregnancy is affected. There are worldwide registries now looking at how patients with MS have delivered and are there any problems with the children who are born. It seems to be quite safe.
Yes, we've had that experience. The babies have been born and they've taken all their vaccinations. And
So in the
obviously-
vaccinations only, the concern would be your BCG vaccine because it's a live attenuated vaccine. So this is specifically in the group of the mothers who had been on highly efficacious therapies like your anti-CD20 therapies. Other than that, the child can have all the regular vaccinations that has been recommended by the norm and the government.
Absolutely. Thank you, ma'am. Dr. Jarna, we've been talking about therapies and things like that. I mean, and that you use as first line of treatment. But is there any, barriers? Are there any, I would say, oh, it's not on? Okay, it's on. Okay, I'm sorry. Okay, so what I'm asking Dr. Jarna is that with all this talk about better drugs, high efficacy therapies, is there anywhere where we need to, think, can this actually be a cause of a problem?
Yeah. So high efficacy drugs, as ma'am has beautifully described in her presentation, these are basically monoclonal antibodies. They have few factors that I want to describe where they can cause as a barrier as a treatment. So one is the barrier factors which the drug itself can cause. They carry a risk of causing more immunosuppression as compared to the other DMTs that there are. These are the injections or these are the drugs which are given via injections. So the patient needs to come to the hospital, get an infusion, get admitted and get an infusion of over 8 to 9 hours. There can be infusion related rash or reactions that we observe, and that's why we admit the patient in ICU for actually giving these injections. So these drugs carry these factors. The other factors is the doctor's factors, that there are two choices, there are two thoughts where one doctor will prefer to escalate the drug from DMT to the higher efficacy, as sir has mentioned. And other thought is to start with a high-end drug and then maybe de-escalate it. So that is the factor. There's another barrier which can, we think when we use these drugs. And then finally, in Indian setup, the patient-related factors is whether insurance will cover it, what is the cost of this drug, and how long to take that drug. That is very unpredictable. So covering with insurance, whether it is available or not, that will also decide whether to give high-efficacy drugs or not.
There's so much about degenerative immunological diseases where MS and optic neuritis, all this there's so much overlap and confusion. So what are the actual ophthalmological manifestations of MS pure?
Yeah. So in MS, as Singhal sir had said, brain, spinal cord, and optic nerve. Optic nerve is a nerve through which we can see things. It goes from the eye to the brain and it carries the impulse from the surroundings and it tells the brain that you are seeing these things. So this is the nerve which carries the impulse. And in MS particularly, this nerve gets affected. There is an inflammation around this nerve which causes swelling of that nerve. So how does the patient present to us? The most common symptoms will be blurring of vision. The patient will say, my contrast has gone. Color ठीक से दिखता नहीं है. Depth vision has reduced. Few patients also have कि मैं आँख हिलाता हूँ तो pain होता है. And blurring of vision, which is धुंधला दिखता है. So all these symptoms correlate with MS. Then there are other ophthalmological symptoms, like patient will say मुझे दो दिखता है. एक जगह दिखता हो तो दो दिखते हैं, यहाँ देखता हो तो सीधा दिखता है. So this is diplopia or double vision. That is also seen in MS, which is affected in the brainstem. Then there are other symptoms like nystagmus, कि सामने देख रहा हूँ तो हिल रहा है. The vision is not stable. So these are few of the ophthalmological symptoms that patient come to us.
Pre-COVID, we had actually admitted quite a few of our MSPs and got clinical. Pre-COVID, we had admitted quite a few of our MSPs, and we had actually got them clinically and investigated them for maybe deterioration, further progress. So how often should we be doing this? Dr. Jaina, could you tell us?
Yeah. So now follow-ups will be both, including your clinical as well as investigation. So clinical follow-ups, roughly, if you ask me, it is 3 to 6 monthly. It is better if you have had a recent relapse. For chronic progressive MS, I think 6 months or once a year is okay, unless you are fine in between. Then MRI, usually if the disease is stable, then once in a year MRI, annual MRI is fine for follow-up. Now, why do you want to do this? What are the reasons why do you want to do clinical assessment follow-up and also MRI? Clinical assessment, well, how are you responding to the treatment? You are on a treatment, whether the treatment is beneficial to you, whether there are side effects, that will only come to know when you discuss with your doctor. So clinical assessment is important in the follow-up. Then secondary is, are there any side effects? And few of the side effects you won't come to know. We observe few things and maybe we can change the drug accordingly and in early manner. MRI, as sir said, there are these syndromes where the patient is completely fine, but the MRI is showing spots. So in such patients, the patient might not have any new symptom, but there are new spots. They may be contrast enhancing also. So in such cases, that's why MRI follow-up is also important.
But when you say clinical, I have a complete panel of clinicians sitting here. So do you think that we should get every patient checked by everybody here?
I think the primary point of contact will be a neurologist. And then the neurologist can decide whether an ENT or an ophthal reference or a physiotherapist reference is to be needed or not.
Fair enough. So I think that's a point that we have to make. Go back to your neurologist, and your neurologist will then tell you who you should be seeing by. Okay, thank you for that, Dr. Raji. Okay. So what are the common ENT problems that MSPs face?
ENT symptoms are common, quite common actually, and we like to look at them as early indicators of MS, and maybe also to monitor the progress of the disease in the long term. Typically, what we see commonly is speech difficulties such as hoarseness of voice with low volume, low pitch, and sometimes later on some spasms or spasticity coming in your voice. Deglutition difficulties, swallowing difficulties, dysphagia, that comes a little later in the disease. What we also commonly see is hearing loss, which is sudden and progressive, with tinnitus, which is a ringing sound in the ears. The next common I would think of is a vertigo, which is a sense of disequilibrium or imbalance or actual rotation, with, like Dr. Jharna said, it has a multidirectional nystagmus, the eye movement that you will see. So these are the common ENT symptoms that we see, and we like to look at it as an indicator of an early diagnosis of MS. There are other uncommon ones which we don't see in India, but they seem, but if the patient comes with those, we should be aware it's possible that they could be indicators of MS, such as smell disorders and taste disorders seem to be very common abroad. It is very common abroad. I think at least in my practice, I have not seen any trigeminal neuralgia or facial palsy, increased salivation. And so these are some other ones which we don't see it, but our antennae should be up that if a patient comes with these disorders, to have this at the back of our mind so that it can be an early indicator of the disease and we don't miss it.
You're right, sir. What would you, recommend as if people were to come to you with, pure ear problems, and what would you recommend? See, these are people who are on extensive treatment for MS itself. So what would you recommend they do?
So you are saying a person diagnosed as MS will come with an ear disorder such as either a hearing loss or a vertigo.
Yes.
So typically the ENT symptoms, the ear symptoms are an extension of the neurological disease most of the time. Though now there are some indications that there could be some peripheral involvement as well, as if for example, if there's vertigo, then you can actually have, or even the hearing loss, there could be some involvement of the inner ear as well. But most of the time, it's an extension of the central neurological disease. So, so let's say if it's a vertigo, then we would like to give vestibular sedative drugs and also vestibular adaptation exercises. If it's a hearing loss, typically, because it's a sudden one, we tend to give steroids. If they're already going on as part of MS, and fine, otherwise, but we up the dose and give it. For speech difficulties and for swallowing difficulties, we again, main things are rehabilitation, swallowing therapies, and they also have, with swallowing disorders and speech disorders, they also have respiratory problems.
Yes.
And there is a respiratory incoordination.
Regurg.
Correct. And also they have lack of concentration while talking, while eating. So those things also need to be looked at.
No, but do devices help in hearing loss?
Devices and assistive devices such as hearing aids will definitely help if the hearing loss is progressive and is not being helped by the steroids and other treatment.
Yeah. Thank you, sir. Dr. Dhawan?
Yes, madam.
I'm sorry, I believe you were in the audience when we were, lighting the lamp.
Yes, I was.
Yeah, we did come. Okay. Yeah, okay. So what about urology? Because we've always found that most of our MSPs have urological problems. So how often do they come? What are their, what are the commonest, I would say, urological problems?
So whenever a neurology patient is referred to us, we usually see their symptoms. We take a detailed history about the urological symptoms. So mostly they present with what we say as storage lower urinary tract symptoms. Mostly there are three types of this. They will present with urgency or urge incontinence. So they will typically say that bathroom पहुंचने से पहले urine leak हो जाता है. Few drops of urine they leak, or they get up very frequently in the night, maybe more than 3-4 times. So that disturbs that sleep and the quality of life is impaired. And the second symptom that they present is voiding symptoms. पेशाब का धार अच्छा नहीं है, or they have to strain while passing urine, or they take a long time to initiate their stream, that is hesitancy. So this is called as mixed symptoms, and we ask them what is predominant symptom. So from our part, as a urologist, we want to improve their quality of life. Already they have been under a long follow-up with a neurologist. So most of them have predominant storage symptoms, that is getting up frequently or leaking a few drops of urine. So as a urologist, we ask them to do something which is called as frequency volume charting. What is the quantity of water or liquid they take in 48 hours or 24 hours if it is possible, and the amount of urines they pass each time, and is there any trigger, something which triggers this leak. We identify that, and first of all we just modify that. We do the lifestyle modification. So maybe couple of hours before bedtime they can reduce their water intake, or madam would be the best person about pelvic floor muscle training. You would come to that, I know. So with these, most of them improve. We also do a sonography to check what is the post-void residue. It should not be that with these severe symptoms their kidneys are getting hampered. Usually it does not happen, but we have to check a look on the upper tracts also, that is a kidney. So if the post-void residue is not too much and they are happy with these lifestyle modifications, Especially, we tell them to avoid chocolates and coffee. These are bladder irritants which
The
can
caffeine.
trigger leaks. So if they are fine, then we don't tend to start them on medication because they're already on lot many medication. But yes, if these symptoms are bothering them, and so then we start them on medications looking at the side effects, and most of them improve with this medication. And the lastly, what we can advise is a urodynamic study to look at detrusor overactivity, any trigger, how much amount of urine is getting leaked, and the bladder pressures. So if the patient comes with a lot of voiding symptoms, is not emptying the bladder completely, is getting recurrent urinary tract infections, is having fever, all those symptoms, then we have to, but no other choice, we have to explain them clean intermittent catheterization. We tell them to empty their bladder frequently, and this reduces their episodes of UTI. And the most important part from our end is improving their quality of life. This is what we can do.
So this self-catheterization that they have to do. What about double voiding?
So yes, before any invasive thing, that is clean intermittent catheterization is definitely invasive. Double voiding and managing their lifestyle modification should be the first part. And if this suffices, then definitely CIC is not required, madam.
Okay. Thank you, sir.
Thank you.
Thank you for the tips you have given
Yes,
us,
ma'am.
MSP. Minal,
Yes.
you actually sort of, I would say, wind up everything before, of course, I go to Sandeep, who's not a medical person. So, Minal, what is the role of physiotherapy? You know, everybody talks of rehabilitation. What is the role of physiotherapy?
Yes. As we all know, the symptoms, clinical symptoms of MS, they vary from patient to patient. Each patient comes with different clinical presentation. So naturally, the rehabilitation protocol should be also very individualistic. It should not be a generalized rehabilitation protocol. And the physiotherapist should first assess and evaluate the patient very thoroughly and then plan out a rehab protocol. So physiotherapy plays a very important role in the patients with MS, basically to improve their mobility, then functional abilities, also thus improving their quality of life. So how to improve the mobility and the functional ability is basically to improve the joint mobility. Also the muscle strengthening protocol can be given, but obviously it all should be a graded protocol, because we have to first judge the strength of the muscle because it is different. So gradually it will be a graded protocol right from the low grade, then the higher graded exercises. Along with that, naturally the fatigue is very common in the patients with MS. So to manage that, the patients need to do a few aerobic activities or the aerobic exercises. Also the breathing exercises plays a very important role in the patients with MS to improve overall vital capacity and the endurance of the patients, because they get tired, they get breathless after a few activities. So this is also very important for them. So also managing the balance, coordination,
Absolutely.
it is very important. For that also the specific exercises to be given. Along with that, the patient's education, the physiotherapist should, there should be a good communication between the physiotherapist and the patient, I feel. Because that is a session, it's like a 1 hour session or like that. But exercise part should not be a very long. There should be a short exercise sessions, but along with that, the communication is very important. So patient's education, telling them what exactly this is and how important the exercises for the patient is also very important. And finally, make them independently, functionally, as far as possible with the customized protocols.
Is it possible
Hmm.
for MSSI to have you physiotherapists, come up with some SOPs so that across all the patients, you have some sort of a protocol?
Yeah. We have a particular, it will be a protocol like the patient should have
they should always look for the red flags while doing the exercises. It is very important because the patient should not do the exercises beyond the limit of fatigue. They should not, push themselves to do the exercise, because in some conditions, yes, we push patients to do the exercises, ki karo, karo, karo. But in such conditions, it is very important that they should do the exercises or whatever the activities that should be within the limit of fatigue. They should not get tired and exhausted while doing the exercises.
Does weather affect, or should it be taken into as a factor in?
No. Not really. But yes, they should be doing the exercises in the comfortable atmosphere. They should not be doing in a very, sweating a lot and doing exercises. Yeah, naturally, they will get exhausted and the further performance will be reduced.
Dr. Khanvilkar, sir?
No, I just wanted to say that if Mronal, along with Dr. Varsha and Dr. Jarna, can create a few guidelines,
yes,
they could be handed over to the MSSI, and then everyone could look at it.
Yes.
So why don't we undertake that?
Yes.
Because we do have a lot of young physiotherapists who come along to us, and I think we should have as some guidelines. Thank you, Mrinal.
Thank you.
Sandeep, if you can wind up the session.
Sure.
Okay, so before we go to Sandeep, if any one of you want to ask any questions of our panelists, yeah, please. Right at the back there.
Hello, sir. Very good afternoon. My wife, she ages 35. She been diagnosed with secondary progressive multiple sclerosis directly. There is no symptoms of RR before that one. We never been through any complaints of RRMS before that. As you said, Khadilkar sir said that firstly patient suffers from RRMS, and then it goes to primary progressive or say secondary progressive MS. Sir, my question is like how it's been almost 1 year and we have taken a dose of ocrelizumab, and she still finding a problem of urinary bladder retention problem and walking imbalance and like stiffness problem. So like I'm confused, does she is suffering through RRMS or is she been through secondary progressive MS?
Right. As we always maintain with these interactions, please do not ask any personal, your patient-related opinion questions. That's for your neurologist to answer in the consulting room. But a part of your question I will answer here because it is pertinent. Most common type is a RRMS going into SPMS. But there are patients like you are describing where the process starts itself in a progressive manner and goes on. That's called primary progressive MS. So there is no RR component. It's not coming, going, and then staying. It stays from the beginning. Now, there is a lot of discussion about whether this is just a type of MS or are there any fundamental differences between those that come and go and then stay vis-a-vis those who stay from the beginning. But in general, the medications that you can offer to people who are primarily progressive are fewer. And at the moment, ocrelizumab is the only one that we have available. So it's good that she's received it. But that's a subset of patients of MS, not that common and slightly more difficult to treat. There was a question at the back.
Thank you, sir.
Hi, this is Samantha here. I am an MS patient since 2012, and over the years I've done treatment and stuff. But I just wanted to understand. I understand that y'all are doctors and y'all are recommending medical treatment and all the MABs in the world, but how do we take these MABs, because it's a regular treatment, once we start it, we can't stop it. Who's going to help us with the money? Because insurance doesn't cover MS. So who's going to answer that? Can you all help me out? Can you all recommend a insurance company that will help me take all these MABs? Because it's a major stress factor for an MS patient. Other than the fact that I have MS.
I'll make a general comment and then pass it on to MSSI. Sure. The general comment is that the cost of medication in India is much less vis-a-vis the cost outside India. It's still very high. It's not that it is low. But thanks to MSSI and its efforts, a reduction in the tax structuring has happened a few years ago, I think. How many?
Basically, representing also.
Yeah.
Three drugs have been.
So I think, so you can tell more about it. So that's one aspect. And secondly, this is a problem of rare diseases. That the force behind this is not that big as you see in cancer or heart attack or polio or things like that. So you want to answer further on that? Yeah.
If I may, just yesterday, Sandeep and I were discussing what one of the companies has done for heart medicine. Okay, I think the injection costs about 2.5 lakhs to 4.5 lakhs.
That's Novartis. I read it.
And what we actually were discussing is whether we could advocate the companies making drugs which are applicable for treatment therapy of MS, whether we could also do that. I mean, this company is actually giving that heart medicine on EMI. Okay, so maybe something like that, you know. Yes, please.
So, hello? Yeah. See, now as far as insurance coverage is concerned, let me come to the crux of it, that in 2023, on 28th February, IRDA, that is insurance regulator, insisted that all insurance companies must cover all the 21 disabilities under a specific policy which is designed for persons with disability. So afterwards, all the companies have come out with the policy, but that policy is unfortunately neither marketed nor easily available. So that is a problem where we are doing a lot of advocacy along with other disability groups. Again, the premiums are also high. However, with that, some of the insurance companies, I can talk personally afterwards, but their important thing is after 2 years of continuous insurance coverage, your existing disability is also covered. In your case, even MS also will get covered after 2 years. And prior to that, all other things will get covered. However, the coverage currently is only up to 5 lakhs. We are looking for even including similarly this particular type of policy under Ayushman Bharat, similar to the one which is given to 70 years above, so that everybody can, all the persons with disability can get it. Right now, only persons with benchmark disability, that is 40% and above, can go for this insurance. So that is another factor. However, as again, the coverage for DMTs is also sometimes doubtful, that there also we are representing that they must be covered as just chemotherapy drugs which are being done, even under OPD, that also must be covered for insurance. So all those things are under progress. However, still, it is worthwhile to go for insurance, whatever is available. Another thing what Dr. Rekha suggested is regarding EMIs or financing for the medicine.
So for that, there are certain schemes which are being worked out. There are some NBFC type of people who are also getting engaged. So we can, you can come out to MSSI, we will discuss about that. So
Sure.
because it's a long topic, we will take it. Yeah.
Sure, thank you. Anything else you'd like to add, Sandeep, about MSSI itself?
Yeah, definitely. So I think they have some queries to the doctors first.
Oh, okay.
So let the medical.
Any queries?
I am Rajkumar Iyer. I am a practicing chartered accountant and I am having secondary progressive. Since most the I was there about 22 years back, and slowly, whenever there is some fever or small episodes, something I lost from using from cane to walker to now on this wheelchair. But one thing I was found is the positive attitude and the I'm working chartered accountant, so I'm even I start my day at 3 o'clock. But the whole meditation and other things helps quite a lot. And so far as the insurance is concerned, I have been covered from the insurance right from beginning from 2002 onwards, getting full claim.
Oh, nice.
I'm just sharing my experience.
Thank you for sharing that.
I am having MS from 2001. Second, secondary progressive. So what happened is my scans are good. 2018 last was done, and one is done very recently. So there are new lesions are not that lesion. Yet my problem has increased a lot. Why is it so? Dr. Varsha madam has put a lot of medicines for secondary progressive. So something can help me.
So, Mr. Patel, as sir said, this probably can be a discussion one-to-one in the clinic with your neurologist. They are looking at a lot of new drugs for progressive MS. As I told you, as I mentioned also, cladribine and the other group, Bruton tyrosine kinase inhibitors. Unfortunately, we don't have it in India as yet, but they'll definitely come. I know of some centers down south where they are taking in trials for cladribine as well. So maybe a few more years down the line, we may get a little more, drugs to add to the armamentarium. Your second question was, why am I progressing? So other than what we call a silent progression, progression irrespective of radiological activity, independent of radiological activity, that's something which a lot of MS experts are discussing. So as the person ages and as the disease inflammation goes on, sometimes even despite having no attacks or not much of radiological white matter changes, there can be atrophy of the spinal cord, of the brain, which then reciprocates as increase in the disability. Okay, this is probably like the natural progression of the disease, which happens irrespective of your being on disease modifying agents.
Anyone else would like to talk?
Rituximab medicine was tried, rituximab, but it did not work for me. So anything else is there?
That's what I'm saying. There are a lot of new drugs which are coming up. It can be
but
discussed
not now.
later.
Not now.
As of now.
Just now it is not available. Oh, thank you.
I have a few questions. I'm a caregiver to a patient suffering from MS. I'll reduce my first question to a single point. Can I give my patient coenzyme Q10, CoQ10? CoQ10, coenzyme Q10. The Dr. Osborne, who suggested that people who suffer from MS, he suggested coenzyme Q10, so that will get the energy go directly to the cell. Can I take it as a note, buy it as an OTC?
You see, coenzyme Q10 is one of the cofactors for added prescriptions. It's not an MS medicine, but there's no harm in giving it. in a lot of neurodegenerative diseases, you use agents like that.
Another thing, she's very heat sensitive, even during the rains. At night, when I get up in the morning and I touch her body, it's cold as ice. So I'm a lay person, yet I want to know that will she be using up a lot of energy into making her body warm? How do I solve this problem of heat sensitivity?
No, I didn't get your question.
A lot of MS patients suffer from, they are sensitive to heat.
Suffer from?
No, they are sensitive to heat.
Sensitivity to heat, yes.
So she wants the fan at full tilt. So in the morning when I touch her body, it is cold as ice. So as a lay person, I was wondering whether the body will use up a lot of energy. How do I solve this problem?
No, the heat sensitivity is believed to be an electrical phenomenon where the nerve conduction changes and symptoms temporarily increase. But our literature doesn't talk about doing anything for it because it automatically comes down. Like somebody takes a bath and the vision becomes worse and it again comes back.
Okay, the third question is Dr. Terry Wall's protocol. What do you suggest? Dr. Terry Wall's, the Wall's protocol.
The Terry Wells protocol, right? Yeah. So I know a lot of MS patients talk about it because there are some who come researching on it and come to me and say, look, I've been using this. There's no harm, as Dr. Singhal has mentioned, that we have to have some dietary modifications. What is the standard of care, and rather what we practice here is we try to tell them to do a modified gluten-free diet. That helps. Diet which is rich in turmeric is also a little help. I am not a very strong proponent of Terry Wall's diet, but there is no harm because they are not extreme diets that you're going to use. So if you are comfortable, you can use it.
Last question is for Dr. Khalilkar. My patient is disappointed in you because you're not available for consultation.
Sorry?
My patient is disappointed in you because you are not available for consultation. She had once come to you for consultation and you sent her to your juniors.
Oh, she can come anytime, no problem.
Yeah, I had a couple of questions. One is the impact that at least I've been seeing with time in terms of ability for concentration, focus, and all of that. I find a lot of changes keep happening. It's very difficult to focus. So any suggestions on how do you deal with that? And the second is the tendency, given all the different health changes that keep happening and MS symptoms that keep happening, the impact it has on mental health. How do you deal with that? Thanks.
Thank you for bringing out this question, Deepa. This is what they call about hidden symptoms of MS. A lot of them will come with mind fog, can't concentrate. Look, I'm getting a little short of my memory. I do something, I forget suddenly. I just can't focus. This is exactly what you described. So it is a part of the MS which not all, if you go in a clinic one-to-one, sometimes these are some things that are missed in the conversation. Because it said, okay, yeah, we are looking at your motor disability, we are giving you drugs, your relapses will be better, this will be better. But what about these? So as Dr. Mrinal was also talking about, prioritizing, okay? Energy conservation techniques. So when you are looking at planning your day, probably write them down. Do the most difficult part initially, and then, say, I'll do task B, C later. Solving a lot of those puzzles or being a little more into reading. What we generally say for anybody who has a little concentration issue, maybe working on that, doing a little bit of yoga, meditation, will definitely help. You want to add something, Dr. Jana?
The impact and how do you deal with issues around mental health which come based on MS symptoms?
Yes. So I wish we had a little more robust network of just picking up the phone and talking to a random person and trying to open up about our symptoms, what they do in US or the European population. We're just speaking to somebody across helps to go down on your anxiety and your mood and everything. So what I would say is best coping is probably confide to someone, talk to someone. It may not be your partner, it may be your friend, it may be your relative. Keep talking about it, because the more you speak about your mental issues, the better you are to cope up with them. So you want to add something?
This is where MSSI is doing a fabulous job. There are a lot of patients who tell that when we speak to a MSSI person, we feel so much better. So I think
Yes, we are doing
that mechanism can be encouraged.
Yeah, we are doing that. We ring up the patients and we actually just chat with them. Yes.
Sir, recently I come with, I have done many researches on MS. So I just met one person randomly. She claims that if you keep your dietary plans very well, so you can come up with the MS, you can counteract with the MS. So can you please suggest, or can you please give what diet should we take to monitor our MS conditions or to decrease it?
I think this was partly asked to Professor Singhal as well when after he finished his talk. See, we are allopathic doctors. Our books contain a certain material about medicines and certain material about diet, no doubt. Like you have a atherosclerosis. How do you reduce it with diet? Our books say that. But for MS, as far as I know, there isn't any particular diet that has been shown to be definitely effective to come in our textbooks or our journals. There's a whole lot of talk about various kinds of dietetic things, and each one of us is a diet expert, so we have so many things going on there. I call these fringe therapies. They are neither mainstream nor are they to be neglected. But that's where they stand, fringe medicine.
Thank you, sir. And sir, just clear my small doubt. Whenever I meet anybody, they say एक एज तक 40 years तक अगर आपको MS होता है तो 45 तक थोड़ा कम हो जाएगा, 50 तक क्लियर हो जाएगा. So ये मेरा डाउट है सर कि ये ऐसा होता है MS के अंदर में या कैसा?
It's not the age. At whatever age you get it, the first year or two are the worst when the inflammation is maximum. Then it starts cooling down. So every immune disease, as we know, cools down with time. And the same thing is true for MS.
I think we've had a wonderful session.
Yeah. I think we can take the last
maybe
one.
that's the last question.
The last one and
Yeah?
then
Hi, good evening. Thank you for fitting me in. I'm Medha. I'm going to graduate as a neurophysiotherapist. So my question, so when we get patients with MS in our department, the two things, the hidden factors, hidden diagnosis, clinical features, which you said, one is pain, management of pain. So now I know that there are many drugs for management of pain. But as a physiotherapist, the management of pain depends on feedback, patient feedback. And that is affected a lot in patients with MS due to the hypersensitivity, hyposensitivity. So our traditional pain management methods don't work. So are there any advances or therapy types that you can suggest? That's my first question.
Yeah, actually, the patients with MS, they come with the pain, and it is more like a paresthesia type of pain, like a sensory impairment type of pain. And in such pain, we can't give them any modalities like diathermy or whatever. We can use the sensory integration techniques for them, like we can use different textures to counter, as a counter irritant, so that will help to reduce its sensory neurological pain. Along with that, we can try TNS. I'm not sure whether, but it helps sometimes. It has an inhibitory effect. So sometimes the tingling sensation or the pins and needles type of sensation, the TENS helps in that. But along with the sensory integration will be more helpful. That's what I feel.
Thank you very much. And I thank all my panelists. It's been a wonderful discussion. I'm sure all my MSPs and the audience agrees. Thank you, doctors. Thank you so much.
Thank you so much.
May I request all of you to wait for a minute, please? Sandeep, I would request you to hand over a token of our gratitude to each one of them. Lakshmi Priya.
Actually, Dr. Rekha, Kranti and Geeta and all the people. Yeah, please come. Please come. Lakshmi. Anaita also, yeah. Anaita, Ramesh. Yeah, all some together. So, big MSSI. Thank you very much. Just a moment, I will just announce actually what MSSI does, because it's important that those of you who are not very aware about what MSSI does. So in simple terms, MSSI is a bridge between doctors, then paramedical people, government, policy makers, and all other stakeholders, and on the other side, MS persons or MS patients. So we are acting as a bridge, and with that, whatever things which are required when somebody is diagnosed with multiple sclerosis, we are giving tremendous support about, first of all, emotional support. Counseling has been done. Then we have various programs for physiotherapy, occupational therapy, and also, whenever possible, we are giving financial assistance also to needy persons. That is one part. We are looking at complete rehabilitation, be help for employment whenever possible, or retraining, reskilling. And even we have done, whenever possible, certain seed capital also for rehabilitation, but it is always on the case-to-case basis. Another important area which I just want to elaborate for 1 minute is advocacy. Advocacy is a very important part, and it depends on numbers. So even a people, some of you who are not really requiring financial assistance, it is important that you need to join hands with MS people, our MSSI, because we are in turn joining hands and collaborating with all other disabled organizations promoting 21 disabilities, so that we can be a collective voice. We are looking at classification of multiple sclerosis as a rare disease in the policy thing. We are also looking at insurance also, which is an important touching point for everybody. As somebody was rightly mentioning, that he's being covered, but that cover must be before he is diagnosed as a multiple sclerosis person, or under group insurance. So that is also another option. If you are working with some of the companies, you must carry on with your group insurance, and simultaneously you take a personal policy which right now which is available. So that is also important way of safeguarding you. So that's all. And whenever any query is there, all our MSSI and MSSI staff are there, and we have 9 chapters across India, and everywhere we have dedicated volunteers. Thank you very much for your attendance, and I really thank all of MS team, MSSI team, who have done this work relentlessly. They have followed up, they have done a complete thing. I specifically thank Kranti, Geeta, then Sapna, Lakshmi, Ravi. Everybody has worked tremendously, and of course our committee members, Dr. Rekha, Anaita, Ramesh Rao, and all others who are not there, but they have contributed a lot. Thank you very much. Of course.
Thank the hospital also.
Yeah, of course. And we are tremendously thankful for Bombay Hospital, Dr. Khadilkar, Dr. Varsha Patil, and for giving us this opportunity and giving this auditorium, and also we are really thankful for that. Thank you very much.